Let me introduce you to our special guest tonight, Dr. Kier Ross. Dr. Kier Ross is a I'll call you a new surgeon in the area. Although you've done your residency at NYU, you've just came on staff with New York Orthopedics. He is in New York City a ton, but he also sees patients in Westchester. Where else do you see patients, Dr. Ross?
So I'm in the city. I'm in Westchester, and then I go out to Westbury, Long Island, once a week as well.
All right.
Nice.
Excellent. Dr. Ross, like I said, did his residency at NYU, did his fellowship at Lenoxville Northwell Health, and is met with us. But more importantly, he did his undergrad at Cornell, where he played college ice hockey.
That's right.
And he was an All-American there, and he was the captain his senior year, and he scored a ton of goals and played and had no minuses ever, right?
That's exactly right. Yeah, you nailed it.
All right. But that brings me to the topic tonight. The topic that we're talking about tonight is clavicle fractures, something we see pretty frequently in ice hockey players. You know, if a hockey player doesn't have an AC joint separation or a clavicle fracture, I question how good of a hockey player he was. So, but with that said, anything else you'd like to say about yourself or reveal, sir?
Yeah, no, I mean that's about it. I appreciate the introduction. I have sustained a couple clavicle fractures and AC joint injuries myself, so I'm glad I met your benchmark.
So he was good then, Tim. See, he was good.
He was
Good enough to get
exactly.
injured. Yeah.
That's exactly. He was good. Totally.
Yeah.
Oh
But
gosh.
no, I think that just about covers it. I mean, just to talk, I guess I could talk about my practice and the kind of stuff I treat.
Yeah.
I mean, I did a sports medicine fellowship, so of course, shoulder and knee arthroscopy and hip arthroscopy are kind of my main, the main parts of my practice. But I do arthroplasty and a fair bit of trauma as well, and take call at a few different hospitals in the area. So I do a lot of fracture work, including clavicles and other higher energy injuries as well. So it's definitely up my alley, talking about clavicles and everything as well. So.
Outstanding. When we talk about clavicle fractures, who gets clavicle fractures? Is it older people? Is it younger people? Is it children? Who's getting clavicle fractures?
Right. So the most common is young men around the age of 20 or sometimes less. Pediatric clavicle fractures definitely are not uncommon, but we worry about them less because, like with any other fracture, in the pediatric population, they tend to heal really reliably and they remodel well too. So they're almost never operative in pediatric patients, but most commonly in male athletes that play contact sports, lacrosse, hockey. And obviously we see them in older patients as well, but certainly less often.
Don't forget about some of the most important athletes on the earth, horse racing jockeys. Okay.
Yeah. Yeah. Also a common one.
They get clavicle fractures quite often. But as do mountain bikers. I was told by a colleague of mine. People that are in Colorado riding mountain bikes, they fall off those mountain bikes. They're falling on their tip of their shoulders usually, or trying to break their fall.
That's what motocross guys too. One of my partners, Joe, is a motocross guy. All his friends have fractures.
Clavicle fractures.
So they must
There you
be.
go.
So they must be good. So
They must be good. Dr. Ross, that brings us to the mechanism of injury. What is the mechanism of injury in your experience for clavicle fractures?
Yeah, so as you kind of alluded to, it's usually a lateral blow to the shoulder. So the clavicle itself or the AC joint or both get loaded when you have a direct blow. A lot of times with the shoulder slightly, dipped down, the clavicle is kind of loaded axially along its length, and then the force dissipates through the bone itself. So again, falling off of a bike or a horse, going into the boards when you're hit in hockey, box lacrosse, things like that are really common risk factors. Football can be a common one too, shoulder to shoulder contact, anything where your arm's tucked in and that lateral side of the shoulder kind of takes the brunt of the force.
I wonder if there's been less in quarterbacks since they penalize you for driving the quarterback into the ground now.
Yeah, I would think so.
I would think so too, but I've yet to see that data. When someone does get a clavicle fracture, is the fracture like right in the middle and it breaks in half? Is it at one end, the proximal end? Is it at the distal end? What is it usually? Do you know? Do we even know that data?
Yeah. So there is data showing that the vast majority of them are midshaft, so kind of in the middle third of the bone itself. And medial, I actually did see medial ones are pretty uncommon. I did see one somewhat recently, but that was in a polytrauma patient that was in a car accident. So it's usually more that kind of situation. And then distal clavicle fractures near the lateral edge of the clavicle are not uncommon, but they're definitely a kind of their own entity. Whether or not they involve the CC ligaments becomes a whole nother variable that gets thrown into the mix, and fixing them becomes slightly more complicated too, based on whether or not you need to do a CC ligament reconstruction or if you can get enough purchase laterally through the plate. So luckily those are more, since they're slightly more challenging, they're a little bit less common, but a midshaft is definitely the one we see the most, and there's data again to show that.
When the
Let me
mid
get
when it's the midshaft one, is the subclavian artery that lies beneath the clavicle usually involved? Is it punctured? Is it what happens with that, or it's okay because the bone protects it? I don't know.
Rarely. So there's also the subclavius muscle in between that provides a little bit of protection.
Okay.
It has been reported, and it's actually one of the few absolute indications to fix a clavicle fracture if there's a significant vascular injury that requires repair. But it's rare. It's reported. I've actually never seen it myself clinically, but it is something to keep in mind when we fix them too. The artery sits slightly posterior to the clavicle, so some surgeons will intentionally aim their screws instead of straight down through the plate. They'll aim them slightly anteriorly just to make sure you stay away from it. I've never had that problem myself, but I have seen it happen before. I'm in a hospital I worked at. Yeah.
Excellent, thank you. So a patient comes into your office or into you're covering a football game, which you do cover. By the way, did Hendrick Hudson win this weekend or no?
They're out, but Valhalla's still going. Valhalla's
Okay.
in their final on Saturday.
Oh, they're in the section finals. Rob, this is
Yeah, yeah.
Westchester football. We cover a bunch of football teams up there.
nice.
So when you go on the field and you feel and you palpate underneath the shoulder pads to see if there's a deformity there and they're complaining of pain right over there. Do you get an X-ray right away? Do you get an MRI? Then do you go op? What's your thought process with that athlete? Let's say it's a football player or a hockey player.
Sure, yeah. So, I mean, step one is what you said, just kind of palpate and see if you can feel, any kind of, a lot of times you can feel a fractured gap if you just walk your fingers along the bone, just go from the SC joint across to the AC joint. And usually if there is a fracture, at least a displaced one, you'll find it. And then if you're worried or you're pretty suspicious, honestly, regardless, I would try to take a look under the shoulder pads and look at the skin itself, because that's going to tell you a lot about how urgent it is. And, if it's a displaced fracture, you'll see that soft tissue swelling. And if that, usually it's the medial fragment that is elevated up by the sternocleidomastoid attachment. So you'll see some prominence there. Even if the skin's not threatened, there'll be a bit of swelling in the area, it'll be more prominent. But the most important part about actually taking the jersey or taking the pads or both off is to make sure the skin's not tenting or threatened. Because if that's the case, it's reasonable to send them to the ER if you're really worried about it. Otherwise, I think it's very reasonable to put the player in a sling and kind of non-urgently get X-rays and see them in the clinic that week. And then at that point, you can have a discussion about pros and cons of surgery.
Right. That leads us to the non-op care. So the non-op care is a sling. It's a sling for how many weeks? 4 weeks, 6 weeks, 12 weeks,
Yeah,
and
about the first two, they're pretty reliant on the sling and just coming out of it essentially to shower and do elbow, hand, and wrist range of motion to prevent stiffness. And then, starting passive range of motion, depending on their level of comfort within the first, 3 weeks or so, and then kind of progressing from there.
do the ones that you treat non-op go on to non-union or not heal? Do you know the literature if they heal or not, or if they don't? And like not every fracture is totally aligned, as you showed me
Right.
in some X-rays in the clinic recently. I mean, you showed me one where it was like they were at like a 45-degree angle. and you're like, oh no, we'll treat this non-op. I'm like, what are you, crazy?
It's kind of a topic that's evolved over the last couple of decades. So and that's kind of the main discussion to have with the patient, and the kind of my main thought process is it's less about, I would say, less about return to sport and less about functional outcome and more about what's the risk of non-union, right? So plating it is certainly has been shown to decrease your risk of non-union. But then to answer your question, it's so how do you know which ones are going to not heal and go on to
Right.
non-union? How long does that take? So the there's a lot of studies that have shown repeatedly what the risk factors are. So one is, and probably the one that's been re-demonstrated the most, is the amount of displacement. So they talk about in most studies 100% displacement, meaning the bone ends are not opposed at all. So there's no cortical contact anymore. So that's probably the biggest risk factor for non-union. Comminution has been shown to be a risk factor. Usually when there's a comminuted midshaft clavicle, it's one or two pieces of comminution right in between the two main fragments. And so if you have two fragments elevated up, usually the comminution kind of almost looks like it's bridging it, and that's called a Z deformity. For obvious reasons, it makes a Z kind of shape. And that has been shown to be a risk factor. 2 centimeters of shortening is a risk factor too. So meaning if the bony ends have bayoneted a little bit by about 2 centimeters, that's a risk factor as well. Female, older patients, smokers, some of those risk factors that have been shown for other fractures as well have been, again, shown to be a risk for non-union and clavicles too. So there's pretty good data for that, and I usually kind of in a simple way lay that all out for the patient. And essentially, there's no score that I'm aware of that you can use to calculate what the risk of non-union is. That exists for tibial shaft fractures, but not yet for clavicles. But it almost just gives you more of a kind of intuitive sense of what their chances are. So if you see a big Z deformity, shortened, displaced,
Right.
comminuted, the discussion is pushing a little more towards surgery. There's a little bony apposition, it's not comminuted, they don't smoke. It's more reasonable to think about just non-operative treatment. And that was, again, like I said, the mainstay for decades until there was more data coming out to show that the non-union rate is probably, instead of being 3 to 5%, and we now know it's more like 15 or 20
Okay.
with non-operative treatment.
When I was preparing for this podcast, I saw something that sometimes non-union can affect scapulohumeral rhythm and cause
Yes.
dyskinesis. That was kind of striking to me. I mean, when we as physical therapists think of scapular dyskinesis, we're thinking about the muscles and how there's not co-contraction and between the forces to produce the proper scapulohumeral rhythm to get the glenoid aligned in the proper position so that the humeral head can pivot off it and function. What happens in the clavicle fracture that they're talking about in some of these articles I read prior to this podcast?
Yeah, no, it's a great question because that's kind of a newer topic in the world of clavicle fractures. So the thought is that especially if you have shortening of the clavicle, so again, 2 centimeter displacement or so, essentially what happens is the acromion is medialized because it comes with the clavicle. So that alters the position of the scapula on the chest wall. And then basically it's mostly theoretical, but the idea is that throws off your scapular thoracic rhythm. So I guess the normal rhythm, as I'm sure you guys know, is 2 to 1, right? So
Right.
for every, X degree of humeral motion, that's the ratio to scapular motion. But that gets altered when the position of the scapula has changed on the thoracic wall. So I'm not sure that that's been quantified exactly, how the ratio is altered, but certainly what's been shown is that strength and fatigability are affected by it. So shoulder strength, because of that shortening, definitely decreases, and the fatigability has been shown in multiple studies, I think, to be negatively affected too.
Excellent. Thank you
Yeah.
educating me on that because I was surprised to see that in the literature. So,
Yeah. I don't know if have you guys
So I have
noticed that when you're
yeah,
rehabbing clavicle patients post-op
yeah,
that they have weakness
I was,
for.
I think part of it, and see what you think, Tim. The
no,
SC
yeah,
and the AC, the SC and the AC joint itself maybe changes the biomechanics or the mechanics within the joint, right? So you're not getting all the orthokinematics that goes with it, because we know when we get full shoulder flexion, we need posterior rotation of the clavicle as part of the kinematics of it. So I just wonder if all that trauma throws off the joints on either end of that. So,
I would agree with you, Rob. That's a great point. Definitely, the conide and the trapezoid become taut. They turn the clavicle posteriorly so that you can get full flexion range of motion actively. I think that's probably it, but I did not see that in the articles I read prior to this podcast.
Yeah, I do wonder how often there's concomitant SC or AC injury with these, and I think it's probably higher than we think. Certainly, even like low grade AC sprains are starting to be shown to be more of symptomatic for a longer period of time than used to be appreciated. So I think probably patients that go on to union and still have that shoulder pain, they probably have some injury to their SC or AC joint or both, and that's why they continue to have symptoms if it, presuming it heals the fracture.
Gotcha. I know that you're a team physician for a jiu-jitsu or what is the martial arts that you work with?
Yeah, so I cover a couple jiu-jitsu academies. They're
Yeah,
a couple of them are MMA gyms that have, kickboxing, MMA guys, and some and some guys that train only jiu-jitsu and wrestling too. So I take care of the guys from a couple of those academies around town too.
nice.
I haven't seen a clavicle fracture in any of those guys yet, but certainly a lot of finger injuries, knee ligament injuries, shoulder instability. So there's definitely a high rate of injury, but luckily for them, clavicle is one of the few things they
They
don't
don't
get
get
as often. I think because it's not like football or hockey where they have momentum. They're
okay,
relatively stationary, you know what I mean? So
right.
unless they took a direct blow right to the clavicle,
They could
you
get
know,
dropped on the tip of their chromium and
that's
break it
true.
that
That's
way.
true from takedowns, wrestlers and jiu-jitsu guys definitely
You
would.
never know.
That's a good point. That's a good point.
Uh, but if you have a professional athlete, whether it be an MMA fighter and they have that rare injury, or a pro hockey player, or a jockey, by choosing to operate, do they get back quicker? Do you decrease their chance of re-injury? What is your thought process on that? If I need to get Connor McDavid back as quickly as
Yeah.
possible for the playoffs, am I plating that or am I going non-op? What would you do?
Yeah, no, that's a great question. So I think a lot of it has to do, I think the short answer is I'd probably be more aggressive about plating it. One is, again, the main reason is still going to be to decrease their odds of non-union, right? Especially if it's just a displaced or shortened or both fracture,
Right.
right? Because you don't want to put them through, X amount of time off, waiting for it to heal. All of a sudden, you're 2, 3 months out, it's not healed, and then you burned all this time.
Right.
And there is some data that they still heal if you wait and then fix them later, the union rate is still the same, but there's a higher risk of other complications like wound issues and need for hardware removal. So certainly I'd be a little bit more aggressive for that reason. And then to answer your other question about return to sport, there's a little bit less data about that. There's data to show that elite athletes get back quicker in general than non-athletes. And there's some data, but not a ton that I'm aware of that shows that the return to sport rate is slightly higher if you fix them. But that data is all over the place. So I think
Right.
probably it it's almost like an ACL where like we tell people 9 months, but it's plus or minus, and everybody's a little different.
Sure.
But that number for clavicles is 3 months plus or minus. Elite athletes get back a little quicker, even if you non-op them.
So that probably we should segue right into our article that we chose to discuss in general. And that was comparing non-operative treatment of clavicle fractures to operative procedures for clavicle fractures. We just bring up the article.
I have a quick question while Tim is doing that. So,
Yeah.
Yeah,
Doc,
sure.
you talk about like subclavius. I know it's such a small muscle. Is it a repair?
Yeah.
Is it something that gets torn? Is it something that we even think about? 'Cause I know it's a good stabilizer, and
Yeah.
it's so tiny, but I don't know what it looks like from your perspective.
Yeah. No, we don't. I can't say you rarely get a great look at it. Sometimes you see it under because at least the way I fix them. Some people fix them anteriorly, and I've mostly done superior plating, and you're looking straight down at the bone. So typically, even if it's displaced, you don't get a great look because the bone ends are overlapped, if anything, and then you bring them out to length. So you don't get really a good look through the gap. I've never seen anybody repair one. It's more of just like theoretically there's some soft tissue envelope there that protects the artery.
Right.
Um, but yeah, no, I agree with you. I think it's a pretty uh I guess not, it's not a very robust muscle. It's pretty thin and wimpy. So
Right.
I don't think it does a ton, but
Right.
it's at least something in between the bone and the
Yeah.
artery.
It's funny because when you read about it, it says like a big, it's a big component of it. But again, I would think it's really not much going on. But this thought is interesting. Thank you.
Yeah.
Thank you. So our article that we're reviewing is out of the Journal of Bone and Joint Surgery, and it's entitled "Plate Fixation versus Non-operative Treatment for Displaced Midshaft Clavicle Fractures." It's a meta-analysis of 6 randomized trials done by the lead author, Sarah Woltz. They're out of Leiden University in the Netherlands, and they hope to compare plate fixation and non-operative care to see which one had more non-unions, which one had more secondary operations, and which one had a better functional outcome. In this study, there was a total of 614 patients, and they were followed up at least a year.
Yeah, so this paper I think is probably one of the kind of more higher quality studies out there on this topic. And then it also answers kind of the biggest questions, right? So I think that's why it's a good article. Um, it, the biggest question, like I mentioned, and again, at least in my mind, is always union versus non-union. And this is probably the highest level of data that supports a lower rate of non-union. Certainly, there's a lot of smaller studies, some systematic reviews that have shown that too, but pretty reliable findings in this paper regarding that. So I think it's a good, you know, reference to have in, the back pocket of surgeons when they're deciding which route to go and how to educate patients for sure.
It was the non-union rate for non-operative treatment. For operative treatment was 2%, and the non-union rate for operative treatment was 16%.
Yeah.
That's a pretty significant difference there.
Yeah, I think so. Yeah. I think if you told somebody that they, improve their odds by that much, I think a lot of people would be more interested in pushing towards the surgery, especially when the complications are not insignificant, but the rate of complication is pretty low. So, articles
The
like this, I think, have made me think a little bit more aggressively about op versus non-op.
Right. And in fact, the rate of secondary surgery, excluding hardware removal, was actually greater in the non-operative patient population than the operative patient, 16 versus 7%. So that I
Right.
found that striking too. That hey, you know what? You're not, even if you don't choose not to have surgery, you're not avoiding surgery, maybe.
Yeah. Yeah.
So
That's a great point. Yeah, I was actually surprised that the numbers were that high too. At a certain point, the trouble with that, I guess, actually, is before I move on, I should say the interesting point about that is, you know, the reason why you do it, right? So, and how you judge non-union. So that's a really common problem in any fracture study looking at non-union is how do you define non-union? So some studies use CT, which is obviously higher sensitivity. Some just use X-ray. Some use clinical findings and X-ray, right? You could have a fracture that's completely non-tender, but the X-ray is somewhere in between. Not all studies have an exact objective definition of what a radiographic union means on X-ray. So how many of the cortices have bridging bone, things like that. So it makes it a little bit less clear what exactly, you know, what exactly to do with that information because non-union is unfortunately not a really well-defined variable. Regardless, certainly those patients that went on to have surgery after non-operative care, of course, were still symptomatic at the very least. So, yeah, I was surprised at how many patients still went on to have surgery.
Yeah, so was I. But a really reliable variable is the outcome scores they use, the constant score and the dash score. And another interesting caveat here is that although the mean differences were only 4.4, and the plate fixation showed a significant difference in these two scores,
Mm.
it reached significance, but was it just a statistical significance, or was it not a clinical significance? And they brought that up in the discussion because
Yeah,
there was less than 10 to 15 points generally is regarded as the minimal difference to be relevant for these scores, and they didn't achieve that significance. So it was very interesting to see that too. So you don't necessarily get better clinical outcomes with the plate than the fixation.
exactly. So, and that's kind of exactly why I was saying my main focus when I think about it is the union rate and not the outcome, because we don't really know. There's some other smaller studies that have suggested maybe the outcome scores are different, but there's a lot of variability in when they took those outcome scores, how far out their total follow-up was. And, the higher quality studies seem to show, like this one, that there isn't a functional difference. It's just about healing.
Mm-hmm. Last point I wanted to bring up about this paper was in the discussion, they alluded to pin fixation and minimal plate fixations. I'm not aware of what they're talking about there. Can you explain to the audience what that is, and do you use that? Is it not used as frequently? And then we'll move on.
Yeah, sure. Yeah. I mean, I would say the main kind of fixation strategies are, I mean, certainly some people make a very small incision and try to slide the plate along the bone. Some people are more prone to opening the incision a little bit larger so that you don't have to retract the skin as aggressively. And then I guess the three main fixation strategies that I'm familiar with are superior plating,
Okay.
versus anterior plating. So with superior plating, you don't have to peel off essentially any deltoid muscle really, maybe a little bit laterally. There's a slightly higher risk of damaging the artery when you drill or put screws in.
What
And
about
then
the
with
nerves up there?
anterior,
What about the
what's that?
neurovascular? What about the nerves up there? The super clavicle nerve, the sensory nerves
Yeah.
up there. Any of the neurovascular bundles up there? Are you worried
Yeah.
about that when doing those surgeries up there?
Yeah, that's a great point. So there's some controversy about that, and in my training, I've kind of heard. I don't think there's much data to support it, so it's mostly surgeon preference and some, intuition. But some surgeons prefer to. There's usually two branches of the supraclavicular nerve that are cutaneous nerves here, and you encounter them essentially right when you get through the skin and subcutaneous tissue.
Okay.
And some people like to preserve them and leave them intact, take time to dissect them out, keep the plate under them, and work around them. Some people feel like it doesn't matter, and basically you end up just retracting the nerves a bunch and pulling on them, whether or not you think you are mean to, and that causes some kind of neuropraxia anyways. So some people ignore it and then just tell the patient you might have some numbness over the area. But the people that preserve them, the theory is that if you don't and you do cut through them, then there's a higher risk of getting a neuroma postoperatively, and they can get symptomatic stump neuromas, basically. I'm
Okay.
not really familiar with any data to show that. I think there's some small studies that have shown that, but at this point, it's just an opinion.
Okay.
Yeah.
Also up there, there's very little skin coverage for the clavicle.
Yeah.
I kind of equate it to the Achilles tendon, where there's very little
Yeah.
skin coverage for the Achilles tendon. So that's what I was thinking about in my mind when I was reviewing for this. And so the infection rates, are they high? Are they similar to the Achilles? Do you have any idea are you getting an infection 1 out of every 10, 2 out of every 10?
Yeah.
What are you thinking?
Yeah, so I'll make 2 points about that. So the infection rate, I think, compared to Achilles, for whatever reason, is slightly lower. I think the infection rate, if I'm not mistaken, is typically below 5%. The real problem with this is just symptomatic hardware, so just painful hardware because the skin is so thin. So unfortunately, we'll often have to go back in just to remove the plate. And like you said, there's not much tissue, especially with the superior plate, there's not much tissue there. And so patients will feel it. Very thin patients can even like see it a little bit. And sometimes that can irritate the skin and, requires another surgery to take it out. So I think, at least in my mind, I worry less about things like wound dehiscence and infection than something with an Achilles, but symptomatic hardware for sure, is something to counsel patients about before the surgery. So most people will tell them about the numbness and the fact that the plate might have to come out later. So it's a lot like an olecranon fracture, for example. There's hardly any tissue there, and those often have to come out. Or if you plate the front of a patella for a comminuted patella fracture, same thing.
Okay. Rob, before we move on to the most important part of this surgical procedure, the rehabilitation, do you have any other questions, Rob?
I know. I was just trying to think of the different types of. So we have plates. Anything KY, K wires, or are they doing anything? Or everything's just plated these days.
Oh, right. Yeah, I think I kind of skipped past that. That's right. So
the contour plate you taught me about, the contour plate?
Yeah. So as kind of a younger surgeon, I've actually only used the pre-contoured plates. So there's plates that are kind of that S shape that sit on top of the clavicle, and they have on the lateral edge they have what are called locking holes in them. So the screws actually are threaded and the screw holes are threaded, so those screws can lock into the plate. So if you have a more distal fracture, it gets you better fixation in that bone. You can get more screws over there. So the pre-contoured plates are really helpful in a lot of cases. And what we're seeing more and more of now is there's a good amount of surgeons that do anterior plating. So those are also pre-contoured, but like I was getting at before, you peel off a little more deltoid, but you don't have to worry about the artery. And actually, there's some newer stuff talking about doing both and doing dual plating, which may decrease the non-union rate, but we'll see. I'm skeptical because you do so much soft tissue dissection. I think you probably disrupt the blood supply to the fracture site a lot, but I know that is becoming more popular. And then the last technique that you mentioned, potentially doing a wire. I've never fixed a clavicle just with K wires. There is a somewhat older technique that I think some pediatric surgeons do because it's minimally invasive and the fixation is a little less rigid and pediatric patients heal more readily. So there's something called a Knowles pin where you can actually put an intramedullary pin down the clavicle itself. It's almost like doing an intramedullary nail for another long bone, and it just gives you relative stability and allows that kind of callus deformation and form in a little bit better alignment.
And you mentioned corticoclavicular ligament. What do you do with it? How do you secure it? Is that the right word?
Yeah, sure. Yeah. So in a midshaft clavicle fracture, I don't think about it, but in those very distal clavicle fractures that are lateral and close to the AC joint, if the clavicle is elevated and that basically demonstrates that the CC ligaments are disrupted, there's basically two things you can do. So going in, I would have a pre-contoured plate with, one of those locking hole clusters distal, like in the lateral edge, so that you can get more screws in that small lateral fragment. If it's too lateral, sometimes you can't get enough fixation there, in which case sometimes you need to supplement it with basically a corticoclavicular reconstruction. So what you do is there's a ton of different techniques on how to do it. It's honestly CC ligament injury with the distal clavicle is probably its own topic, but you can use allograft or autograft tendon and loop it underneath the coracoid and then either fix it to the bone or the clavicle itself. Some people use like a non-absorbable suture, a heavy non-absorbable suture, and do something similar and loop it under the coracoid and then around the clavicle, and then you tie it down and bring it down that way. My preferred technique, actually, which is somewhat newer system that some implant companies have, is you can put a tightrope or a button through the plate, and then the plate actually has a hole that's made for the button to sit in. So with the X-ray, you can drill through the plate and down into the coracoid, and then basically this suture button device goes from underneath the coracoid and through the plate, and then you use the suture that goes through the two buttons to cinch it down, and that compresses the clavicle back down by being under the coracoid base, and that's how you get your reduction.
Don't give it all.
That I find the easiest.
All right, don't give it all away because we got to cover CC in the spring.
Oh, okay.
All right.
Sorry about that.
I'm messing up your next
Nah,
episode.
that's all right. No, I appreciate it. Tell us about your rehab guidelines. I know that personally from working with you. They're in a post-op. They're in a sling about a week or two, and you allow pendulums right away. What else?
Yeah. So yeah, exactly. First couple weeks in a sling, elbow, shoulder, elbow, hand and wrist, range of motion right away, and gentle pendulums. And then the first, 3 weeks are essentially just passive range of motion under the supervision of, a therapist. And, I think most surgeons do no forward elevation above 90 or 120 degrees at least, or at most. And so just passive motion early on to just prevent stiffness of the shoulder. And then after about 3 weeks or so, that's typically when we start active assisted motion. And then between 3 and 6 weeks, you kind of start progressing towards once you're at the 6 week point to start doing active range of motion and then without an assist. And then somewhere between I would say between 6 and 9 weeks, you can start to do some strengthening, usually around 8, 9 weeks with some resistance, progress from there. And then by the time, you're at 12 weeks, as I mentioned before, around 12 weeks or so is where I feel comfortable, talking about return to sport, maybe a little more aggressive with an elite athlete, but for most athletes, that would kind of be the ballpark.
How do you make the determination when to start that training and start that return to activity? I've always been taught by some of my mentors by callus formation. If you have good callus formation, you can progress. If you don't have good callus formation, you kind of need to wait till it happens so that you're not pulling apart the fracture. Is that still the
Right.
case? How do you look at that? How do you even judge callus formation? I mean, is it
Yeah.
a cloud on an X-ray? I'm not sure.
Yeah. No, so that's a really good question, actually, and it brings up a few points. So I think the short answer, I keep giving you long-winded answers, but the short answer is I think it's controversial. But I would say it also depends on how you fix it, right? So if you have a comminuted fracture and you just bridge across it, meaning you don't compress it at all,
Right?
then you will see callus formation on the X-ray, and then you can use that as a guide to figure out how much healing there is. If you don't do that, and let's say it's just a straight midshaft that displaced a lot, and you get the bony ends perfectly posed, you can either put a compression screw across it and then put a plate, or you can actually use the plate to compress it when you fix it. And when you have rigid stability like that, we call it absolute stability, with a compressed fracture, the bone doesn't heal with callus formation. So you won't see a callus and it becomes very hard to judge. So then it becomes basically only clinical. So essentially, once the wound heals, you're going to get, they're not going to be tender from that, but you can at least palpate the fracture and see if they have pain over it and see if they have pain with motion. So it's a little bit more of a gray area, I would say. Some studies use CT to assess callus formation, and that's certainly objective, but clinically, I don't think it's usually justifiable to get a post-op CAT scan on everybody.
Okay. When you're returning that hockey player back to the ice and full contact, but they've done return to activity in that 8 to 12 week period. Now, 8 to 10 week period. Now it's 12 weeks. They're out. They're skating. Does it matter if it's their top hand or if it's their bottom hand? Because a different load is produced on the clavicle by having it be their top hand or the bottom hand.
Interesting. Yeah, that's an interesting question, actually. Yeah. So correct me if I'm wrong. I would think that the bottom hand is probably higher risk. I mean, one, because of your position when you're near the boards, you're probably more likely to go into the wall with your
Yeah.
shoulder tucked down a little bit with your on your bottom hand side. And then
You're loading
two,
your bottom hand gets loaded much more than your top hand.
for sure, anytime you shoot, definitely
Right.
one timer,
So
slap shots,
yeah.
for sure. Yeah.
So probably doesn't make a difference, is what you're telling me. It's what I'm reading.
You tell me. I don't know. I'm not aware of any
Uh,
difference. I'm not aware of any objective data about that, but I would intuitively think bottom hand. I don't know. Did you see something about that?
no, I did not. I was at the NHL Players Association conference, and the topic came up, but there was no consensus. So I wanted to hear what your thoughts were. That's all.
Yeah,
'Cause,
yeah. My vote's bottom hand is worse.
yeah, I hear you. That's all that's how I had. I mean, if there's any take home messages or anything you want to tell the audience before we open it up to questions, I'd love to hear. But certainly that was extremely informative for me. I learned a ton tonight. So is there any take home message that you like to tell the audience?
Yeah, sure. No, I appreciate it. That was a good it's definitely a good discussion. Yeah, I think the big things are, you know, how do you decide operative versus non-operative? So those prognostic factors are, the amount of displacement, shortening and the comminution. And then there's some other variables like older age and smoking and female gender that are probably risk factors, but less of a slam dunk than just the displacement. Um, and then, the important thing to remember is, you know, fixing them is not really going to change functional outcome, most likely. But the idea is to lower the risk of it not healing.
Okay.
Um, and then, certainly there's plenty of patients that go on with non-operative treatment to non-unions that are asymptomatic that are fine, or they go on to having a malunion that doesn't, meaning it's very deformed still and don't have pain. But I think the other take home is it'll be interesting to see, over the next however many years, what we find out about the significance of the effect on scapular thoracic motion. And if
Sure.
that's something that we've been missing, for all these years, is that another reason to fix these is because, that gets disrupted and patients that are, you know, need their upper extremity strength and endurance, maybe that would be another reason to think about fixing them is if they rely on that. So,
Right. My final question is, when I was working with some college hockey teams and some professionals, they use bone stimulators. Is there any evidence that a bone stimulator helps speed up healing in the clavicle, or
Mm.
outcomes that showed, hey, you know what, a bone stimulator is the way to go with clavicle fractures in athletes?
Yeah. Maybe for a fracture you're treating non-operatively. I think
Mhm.
if it's minimally displaced, but it's a high level athlete that you want to make sure you're not wasting any time. I think it's a low risk intervention to add on there. I'm not aware of any specific data for clavicles itself, but
I'm not either. I was
um,
wondering. All right.
yeah, it's something to think about though,
We
for
might have
sure.
to, Doc, we might have to do that study.
Yeah, that's not a bad idea. There we go.
All right. Rob, you have any questions? Or Donis, you want to open it up to what's in the chat?
I don't see anything in the chat, but let's see what we got.
I got a question for you guys while we're kind of opening
Yeah.
up the floor.
Go
What
ahead,
do you
Doc.
what do you guys think are from a rehab standpoint, whether they're post-op or they're not being treated non-operatively? What do you think the difference maker is? Is there any specific muscle group or exercises that really you think push patients over the edge to kind of have a better result, whether it's with their strength or their time to return? Is anything, even just anecdotally, that you guys have noticed?
Coming from my athlete training background, I like to give some extra protection to these athletes when they return to play. So we'll use a girdle underneath their shoulder pads, or we'll use an AC joint hard donut pad that they sell, and we'll use that. So in terms of the athlete training thing, I'll let the physical therapist, Rob,
Nice.
chime in on what he thinks about the rehabilitation piece of it.
Yeah, I mean, from the manual therapy side, I always think of we have a pyramid way of thinking, like mobility trumps stability. Make sure I think therapists miss that there's areas around it. And because you have a trauma to the clavicle, there's ribs and thoracic spine that have to get moving and everybody gets stuck. So it's a matter of
Mm,
addressing that mobility deficits, get them in a good position, activate the muscles, and strengthen it. I think sometimes as a profession, we go right to, oh, let's get them stronger, but let's get the mobility, let's set up the base
Mhm.
and then move forward from that. That's kind of a, I think, we all have
interesting.
similar exercises we do. I think sometimes it's what we do is how do we sequence it might be a bigger change, so that's,
I see. So kind of keeping not just the shoulder moving, but other, adjacent joints moving
Yeah.
and mobile and avoiding stiffness even before strengthening starts.
Right,
That
because
makes a
you're
lot of
somebody
sense,
who's
yeah.
stuck for, you're in pain, so you're stuck forward in
Yeah.
more of a kyphosis. T-spine can't extend, or your ribs have that ability to torsion. Maybe they don't have that normal mechanics, or they're just holding because of pain. Get them to
Sure.
move those areas, then kind of progress as an exercise with a good base. But
Yeah.
Yeah, that's interesting. Thank you.
All right.
somebody what's
Looks like
that?
we have a question, I think. Yeah. Maybe a couple.
Agree. As avoiding girdle elevation compensation patterns. Yep. So as they go through it, we have good biomechanics related to it. So I agree.
Totally agree with that.
I see. Interesting. So how do you guys go about doing that? You just kind of, as they're doing shoulder exercises, you just kind of depress their scapula, or how do
could
you
do it.
manage that?
Well, I think of the mobility part. If they have to, if it's stable. I mean, we could test, does the SC joint have good arthrokinematics to it? Does the AC joint? Does the,
I see.
can they extend through the T-spine? So you kind of look at it from a mechanical, and then from there, I think once you put, in my opinion, Tim, feel free, but sometimes you put the joints in its best resting position, the muscles will now function better because I'll lend tension. If I'm stuck like this and my upper trap is really lengthened and my lat is really tight, if we get the muscle imbalance first, then the muscles that are lengthened have an easier ability to get stronger because they're not stuck in this tension position where they're so stretched out they just can't get good active myosin activation. So if we get them in the right position, a lot of times there are some thoughts of thinking that the mobility part is the key, and then from there you'll get stronger, continue to do exercises because you put them, they can move correctly in a proper pattern.
Somebody just
Okay.
texted about mirror therapy. Is that what the person said in the text? I can't see it.
Yeah, that is what it says. Yeah, mirror
but I'm
feedback
not
with
so
scapular
sure
plane.
there's evidence for mirror therapy for that. There's mirror therapy definitely for disuse and stuff like that, but I'm not so sure that there's evidence for mirror therapy for that. So
I think I think they're talking about using the sequence of using the mirror, not as a
okay, all right,
like
yes,
like complex PRPS type of thing, more from as you're doing it.
Totally agree.
Activate.
We use a lot of mirror for biofeedback in our clinic for sure. Definitely. All right, Dr. Ross, thank you so much, and we'll see you soon. All right.
All right, guys. Yeah, really appreciate it.
All right.
This was fun. Thank you.
Bye bye.
Take care. Bye.